Hello, I'm Gregory Weir. I'm a vascular surgeon, hyperbaric physician, and wound care specialist. I'm based at the Vascular, Hyperbaric and Wound Care Unit of the Life Eugene Maria Hospital in Pretoria, South Africa. This presentation is on oxygen and perfusion strategies as therapeutic options for wound healing. The whole process of respiration can be summarized in one sentence. The body needs more oxygen, and the body needs to get rid of carbon dioxide.
Respiration serves as a means for the body to exchange gases with the atmosphere via the blood. The partial pressure of oxygen, PO2, in the air in the alveolar spaces in the lungs is greater than the PO2 in the blood, so oxygen diffuses into red blood cells from air in the lungs. Also, the partial pressure of carbon dioxide, PCO2, in the air in the lungs is less than the PCO2 in the blood. So carbon dioxide diffuses out from red blood cells and into the air in the lungs. Oxygen-rich blood is carried through pulmonary veins to the heart and then pumped through systemic arteries to the body. The PO2 in the blood is higher than the PO2 in the body tissues, so oxygen diffuses out from red blood cells at the body tissues. Also, the PCO2 in the blood is lower than the PCO2 in the body tissues, so carbon dioxide diffuses into red blood cells there. Oxygen-poor blood is carried through systemic veins back to the heart and is pumped through pulmonary arteries to the lungs, where gas exchange again replenishes the blood with oxygen and removes carbon dioxide.
Oxygenation strategies can be utilized to facilitate the process of wound healing. Some of these could involve improving the patient's lung function. Others would involve additional oxygen supplementation and even hyperbaric oxygen therapy. Some of these conservative oxygenation strategies would include smoking cessation, optimizing respiratory function, optimizing cardiac function, optimizing medical therapy, correcting anemia, and physiotherapy. Within the context of wound care, transcutaneous oximetry or transcutaneous oxygen pressure is quite essential.
Of oxygen is 160 millimeters of mercury. This is diluted in the lungs with water vapor and carbon dioxide, so that if we were to measure the oxygen partial pressure in the arterial blood, it would be approximately 100 millimeters of mercury. Oxygen is then carried via the vasculature to the tissues, where it is possible to measure its diffusion through the skin using a heated electrode to 44 or 45 degrees centigrade. The transcutaneous oxygen tension in a normal person is about 70 millimeters of mercury. Values lower than 40 millimeters of mercury are associated with impaired wound healing, and values lower than 30 millimeters of mercury are indicative of critical limb ischemia.
Transcutaneous oximetry is an indirect measurement of oxygen levels within the skin itself. It reflects the potential of the skin also to heal. TCPO2 is influenced by the inspired partial pressure of oxygen, pulmonary disease, peripheral vascular disease, edema, inflammation, ambient temperature, as well as the use of nicotine and even caffeine. Transcutaneous oxygen measurements should always be correlated with the saturation of oxygen. TCPO2 should be measured while the patient is inhaling room air. The normal value would be in excess of 50 millimeters mercury. Impaired wound healing would be reflected by a value of less than 40 millimeters mercury. Critical limb ischemia would be indicated by a value of less than 30 millimeters mercury. This also has a negative predictive value. If a patient is subjected to an oxygen challenge test, the TCPO2 level is measured while the patient is inhaling oxygen. One would expect that this value would increase if the patient had a patent vascular system. A patient with an oxygen challenge test who has values exceeding 100 millimeters mercury has a normal response to oxygen. If the patient's values do not increase while inhaling oxygen, the patient probably has significant peripheral arterial disease and needs to be reassessed as far as his vasculature is concerned. As mentioned before, the oxygen challenge test involves 100% oxygen with a non-rebreather face mask. Values of excess of 100 millimeters mercury when doing a transcutaneous oxygen pressure is normal. Values less than 30 millimeters mercury indicates severe vascular disease. If the patient has been subjected to intervention, it might be of value to repeat the TCPO2 more than 3 days after the intervention. Hyperbaric oxygen challenge. This involves exposing a patient to 100% oxygen at a pressure of 2.5 atmospheres absolute inside a hyperbaric chamber. One would expect the patient's TCPO2 levels to exceed 200 millimeters mercury to indicate or predict a potential benefit as far as wound healing is concerned. However, if the TCPO2 levels are less than 200 millimeters mercury, it is unlikely that such a patient would derive any benefit from hyperbaric oxygen therapy as far as wound healing is concerned. A patient with a chronic wound is subjected to a TCPO2 test. The TCPO2 value of more than 40 millimeters mercury indicates that the patient will heal spontaneously. If the value is less than 40 millimeters mercury, the patient can be subjected to an oxygen challenge. If the TCPO2 remains or increases to above 100 millimeters mercury, there is no evidence of any significant vascular disease. If the TCPO2 during the oxygen challenge remains less than 30 millimeters mercury, the patient has severe arterial disease until proven otherwise. Such a patient must be referred to a vascular surgeon or undergo further investigations. Other than the conservative measures that can be utilized to enhance a patient's oxygenation, certain interventions can also be utilized. This could include normobaric or hyperbaric oxygen therapy.
There are a few different ways we can deliver supplementary oxygen to our patients, but how do we decide which device to use? Current thoughts on oxygen is that we should give just enough to allow a patient to have a normal oxygen saturations. That's normal for them, so for a healthy young person, that may be 97 to 99%. For an older person, it may be 94 to 97%. And for a patient with a type of COPD who relies on hypoxia rather than hypercarbia to drive respiration, 88 to 92% may be acceptable. Oxygen flow rates, not percentages, are controlled via the oxygen port attached to either an oxygen cylinder or piped oxygen through the walls. In the UK hospital, oxygen cylinders are usually black with a white top. Nasal specs are a nice way of delivering small supplementary amounts of oxygen to our patients. They have the advantage of being more comfortable and more convenient than a mask and allow the patient to eat and drink while still getting extra oxygen. The disadvantage of nasal specs is we can't really deliver a high rate of oxygen, so we can only use it for lower levels of supplementary oxygen from 2 to 4 litres a minute, which equates to approximately 28 to 35%. The simplest type of oxygen mask relies on the flow of oxygen to deliver the percentage of oxygen required. The higher the flow rate, the higher the percentage of oxygen delivered. That said, it's not very accurate. The faster the patient breathes in, the more air is entrained via the sides of the mask and mixed with the flow of oxygen, diluting the oxygen that's inhaled. Venturi masks are a good way of controlling the percentage of oxygen being delivered, but also allowing higher flows of oxygen-air mix. Each Venturi valve has a percentage of oxygen on it and a flow rate required to deliver that percentage. The valve has small slits in the side through which the flow of oxygen down the middle drags air in to equalise the pressure differential. It is known as the Venturi effect, and because this effect is calculable, we know how much oxygen is being delivered. To change the level of oxygen, change the valve, which come in a variety of percentages from 24 to 60%. The flow of oxygen is very drying, and one way of overcoming this is to use humidified oxygen via the system you see here. The percentage of oxygen is controlled by this adjustable valve and the flow rate using the same Venturi effect, but in this case the oxygen is passed through distilled water to humidify it. The downsides, it's noisy, it's wet, and it has to be changed regularly due to the infection risk. So what do we do with a patient who needs more? Well, we can use a non-rebreathing mask, which is like a normal oxygen mask but has a reservoir bag. We've already discussed that with a simple oxygen mask, air is entrained in via the size of the mask as we tend to breathe in much faster than the flow of oxygen. The non-rebreathing mask gets around this by having a reservoir full of oxygen for the patient to draw on. Although some air is still entrained using this method, we can deliver up to 85% oxygen to our patient. For the non-rebreathing mask to work, the reservoir bag must be inflated before use, we must use 15 litres flow of oxygen, and the mask must be tight-fitting to draw oxygen from the reservoir bag and limit entraining. Any patient requiring this level of oxygen has something wrong with their oxygen uptake and requires specialist referral. This method of oxygen delivery is not supposed to be a long-term thing. The final thing I want to talk about is not a device for delivering oxygen, but a device for delivering certain drugs, the nebulizer. The nebulizer has a chamber where liquid drug is put. Air or oxygen is then passed through this chamber, which turns the drug into a fine vapour to be inhaled by the patient. You will struggle to get the flow of oxygen or air in a nebulizer much above 8 litres per minute, as the back pressure from the chamber will cause it to blow off the wall.
When a patient with a complex wound is exposed to hyperbaric oxygen therapy, certain changes take place within the dermis subcutaneous tissue. In the first place, the patient has an accelerated rate of healing because of the increase in the amount of new blood vessels, reduction in edema, appropriate inflammatory response from the white blood cells, as well as an increase in metabolism, all contributing to an accelerated rate of wound healing. Problem wounds, including diabetic ulcers, compromised grafts and flaps, thermal burns, and crush injuries, all respond well to hyperbaric oxygen therapy. We will now discuss a few strategies to improve perfusion for the sake of wound healing.
Have a closer look at your nails too. And if you could turn them over for me. That's great, thank you. I need to assess the temperature in your hands and arms now as well. That's great. So I'm just going to squeeze on your fingers now, Colin. That's fine. Okay, Colin, I'm just going to feel your pulse now. And your other pulse too. That's fine. If you could just straighten your arms out for me. Excellent. And at this point, Colin, could I just ask that we put the bed down flat? Yep. Excellent. I'm just going to have a feel in the centre of your abdomen now. It might be a little uncomfortable. That's fine. And I'm just going to have a listen on your abdomen now. Alright. I'm just going to have a look at your legs and your feet now, Colin. Right. I'm going to have a look at your toes now. And if I could ask you to lift your right leg up, please, Colin. That's great. And your left leg now, please. Excellent, thank you. And can you wiggle your toes for me, please, Colin? I'm just going to assess the temperature in your legs and your feet. And I'll press on your toes. I'm going to feel the pulses in your feet and your legs now. And if you could let me take the weight of your leg now, please. I'm going to have a listen behind your knees now. Again, just let me take the weight of your leg. And your left leg. I'm just going to feel the pulses in your groin now, Colin. Could I ask you to lower your boxers slightly?
Yep.
I'm just going to have a listen to the pulse as well. Finally, Colin, I'm just going to assess the sensation in your legs and your feet. So I'm going to use this bit of cotton wool and it'll feel just like this. If you could shut your eyes for me now and let me know if you feel this on the right or the left leg.
Okay. Right. Left. Right. Right. Left.
The ankle brachial index, you will first need to measure the arm blood pressure with the Doppler probe. It is important to choose a sphygmomanometer cuff of the appropriate size. This is placed over the upper arm. Palpate the brachial pulse and apply gel with the probe at the site where the pulse is felt. Place the Doppler probe lightly on the gel at a 60-degree angle towards the patient's head. Inflate the cuff rapidly until the brachial artery flow ceases, no further Doppler signal, and continue for about 20 to 30 millimeters of mercury above this value. Following this, deflate the blood pressure cuff slowly at 2 to 4 millimeters of mercury per second in order to note the systolic value. You can then wipe the gel from the patient's skin and repeat the procedure on the other arm. Following measurement of the systolic blood pressure in the upper extremities, measure the systolic blood pressure in the lower extremities. First, place the cuff above the ankle. The dorsalis pedis artery is located initially by palpation or identified by Doppler alone if no pulse is felt. You should obtain an arterial Doppler signal, which can be monophasic, biphasic, or triphasic. Apply the Doppler probe to this area and inflate the blood pressure cuff to 20 to 30 millimeters of mercury above the level of flow cessation. Then slowly deflate the cuff until you hear the sound of the systolic pressure and record it. Repeat the procedure for the posterior tibial artery. Once you have completed the measurement, remove the cuff and place it over the contralateral leg. Repeat the procedure for the contralateral dorsalis pedis and posterior tibial arteries. To calculate the ankle brachial index, divide the systolic blood pressure from the ankle by the systolic blood pressure from the arm. Use the higher systolic pressure from the dorsalis pedis or posterior tibial artery for the calculation of the ankle blood pressure. Also, use the higher brachial systolic pressure as a lower arm blood pressure may be due to arterial occlusive disease in one of the upper extremities. A normal ankle brachial index at rest ranges from 0.91 to 1.3. Above 1.3, you should suspect that the patient has incompressible vessels. Decreases in the ankle brachial index are consistent with peripheral arterial disease. Mild to moderate peripheral arterial disease usually produces an ankle brachial index in the range of 0.41 to 0.9. Below 0.4, severe peripheral arterial disease is usually present. Depending on the presentation and symptoms of patients, you may decide to perform additional investigations such as angiography, magnetic resonance imaging, or duplex ultrasound scanning. There are limitations to the measurement of the ankle brachial index. These include the presence of a subclavian artery stenosis. If bilateral, this will falsely elevate the ankle brachial index. Calcified and incompressible vessels in the lower extremities will also falsely elevate the ankle brachial index. These conditions are often found in the elderly, in patients with long-standing diabetes, and in patients with renal failure who are on dialysis. Measurement of the ankle brachial index represents a non-invasive and objective way to diagnose peripheral arterial disease. This test has been reported to have more than 90% sensitivity and more than 95% specificity for the diagnosis of peripheral arterial disease.
Conservative perfusion strategies include smoking cessation, optimizing cardiac function, optimizing medical therapy, supervised exercise therapy, and formal assessment of arterial supply. Intervention should be considered when a patient experiences rest pain, when the patient has a non-healing ulcer, when the patient has evidence of gangrene, or where the patient has impaired quality of life due to significant claudication. Claudication is difficulty in walking ascribed to insufficient arterial circulation. Blood vessel is. After the location of the stenosis has been confirmed and the degree of stenosis has been established, it is possible to pass a guide wire beyond the area of stenosis and then to place a balloon across the area of stenosis, carefully inflating the balloon in the process called angioplasty. Dependent on the degree of stenosis, the location of the stenosis, and the post-angioplasty radiographic appearance of the stenosis, angioplasty itself might be sufficient, but in selected cases, stents are placed as well that function as a scaffolding to maintain patency of the blood vessel. In this video, a more significant stenosis or occlusion of a blood vessel is addressed by means of a contralateral retrograde puncture with a guide cath that is placed into the right femoral artery. Because of the complete occlusion of the blood vessel, subintimal access is attained to the distal part of the superficial femoral artery at the junction with the popliteal artery. Balloon angioplasty is done over the guide wire to facilitate the process of advancing a stent at a later stage. In this case, a covered stent graft is used. The covered stent graft consists not only of a stent, the metal component, but also of a PTFE component. PTFE is a material that is known to have very little resistance against blood flow. The rate of restenosis is also considered reduced with this form of intervention. The whole area of stenosis is addressed by means of balloon angioplasty, as well as covered stent graft, which is then approximated against the blood vessel wall by repeat balloon angioplasty afterwards. The inner lining of this specific stent and prosthesis has a heparin layer to reduce the risk of thrombosis. As soon as the patient's blood supply is restored, the ability to exercise is increased. And if the patient had a critical limb ischemia with a distal wound, the ability of the wound to heal would be improved as well. The endovascular techniques are less invasive and include angioplasty, angioplasty with drug-coated balloons, angioplasty and bare metal stents, angioplasty and drug-coated stents, and angioplasty and stent grafts as depicted in the previous video. Not all cases are amenable to endovascular techniques. In selected cases, we make use of peripheral bypass surgery. Peripheral bypass grafts are still the mainstay of treatment for patients with critical limb ischemia and have a high success rate. In this picture, a femorodistal bypass is demonstrated where the common femoral artery is exposed proximally, the posterior tibial artery at the level of the ankle is exposed distally, and a long saphenous vein is harvested and reversed for a femorodistal bypass. The success rate associated with peripheral bypass surgery where the vein is used is considered to be in excess of 90% limb salvage. In selected cases where the vein has already occluded and there is no access to any vein in the patient, we might resort to making use of a prosthetic graft, in this case a PTFE or polytetrafluoroethylene graft with heparin bonding. Surgical technique for access to any blood vessel involves getting proximal as well as distal control of the blood vessel and making sure that all of the side branches are controlled as well. When we do a peripheral bypass operation on a patient, it's essential to expose both the proximal and the distal blood vessel, making sure that we do not cause any damage to the blood vessel at all. After exposing the blood vessel, we control the blood vessel proximally as well as distally before exposing the blood vessel. In this video, access to the blood vessel is obtained by means of incising it with a knife. The incision is elongated proximally and distally with scissors, and then the plaque is exposed on the inside of the blood vessel. We try and remove as much of the plaque as possible to enable good flow through the blood vessel. Both the proximal and the distal anastomosis of the graft onto the artery is made by end of the graft to the side of the artery anastomosis with circumferential sutures that are non-absorbable. Hemostasis is obtained. That concludes this presentation. Thank you for your attention. Please visit vascular.co.za or hpo.co.za for more information on vascular surgery and or hyperbaric oxygen therapy.